Introduce yourself to the patient and explain that you're assessing the chest drain's function. Make sure the patient knows this is not going to be uncomfortable. Start by inspecting the chest drain. The drain should be secured with sutures and then also a clear dressing which allows inspection of the insertion site. Inspect the insertion site looking for blood or pus. You can also assess the depth of drain insertion if possible by looking at the centimetre markings on the side of the drain. This may give you an indication that the drain has moved or migrated out. Inspect the dressing to ensure it's clean and intact. Look for any surrounding swelling or erythema, redness, and feel for any surgical emphysema, air under the skin. Check the integrity of the circuit. Ensure there are no kinks and that all the connections are secure. We often place tape over any non-Luer lock connections to minimise the risk of accidental detachment. Make sure the three-way tap or valve is correctly orientated, i.e. ensure the drain is open or clamped as intended. We have a separate video on clamping a chest drain. Ensure the bottle is resting below the patient's waist height. Look for swinging. You may need to look at the actual chest drain close to the patient's chest wall, or the chest drain tubing, or even the column in the chest drain bucket. You may need to ask the patient to take deeper breaths than usual. Remember that swinging is an indication that the drain is in the correct place, that it's in the pleural space. If there is no swinging, it implies that the drain has either become dislodged, is kinked, or blocked. If you've already established that the drain is not kinked, then it's sensible to flush the drain at this stage. We have a separate video for this. Flushing a chest drain with 20 ml of sterile saline can be done aseptically by any nurse or doctor who has had the relevant training. Look for bubbling. Bubbling is a sign that there is a pneumothorax, that there is air in the pleural space. Not all drains will bubble, only those in patients with a pneumothorax. If the drain is bubbling, meaning you can see bubbles entering the chest drain bottle as the patient breathes or talks or coughs, then it's helpful to quantify this. Is the drain bubbling a large amount constantly, a medium amount or bubbling only on talking, a small amount or only intermittently, such as only bubbling on coughing? Remember, never clamp a bubbling chest drain, even if the drain is only bubbling intermittently. This drain is bubbling aggressively. It's constantly bubbling and implies a large air leak. This drain is bubbling moderately. It's bubbling as the patient breathes out or talks. Next, measure the amount of fluid in the chest drain bottle since the last set of observations and note down the colour and the appearance of the fluid. Is it clear? Purulent, meaning pus, sanguinous, meaning frank blood, serosanguinous, meaning blood stained, milky, or straw-coloured. It's often helpful to mark the bottle at the fluid level with a Sharpie and label the time of the assessment. When fluid is drained, it's vital to ensure large volumes are not drained in short periods of time. This aims to prevent the serious complication of re-expansion pulmonary edema. In order to drain safely, no more than 1,500 ml should be drained in the first hour after chest drain insertion. And after this, no more than 500 ml should be drained in each subsequent hour. If the drainage exceeds this, the drain should be clamped for 2 hours. It's worth noting, however, that some patients can experience difficulty breathing after draining even smaller volumes. If a patient does experience breathlessness or chest tightness after smaller volumes of drainage, you should clamp the drain earlier. Finally, ask the patient if they're experiencing pain relating to the chest drain. At the end of your assessment and prior to documenting, ensure the patient's clothing is reapplied and secure and that their call bell is within reach. After your assessment, you may also need to do one or more of the following. Give the patient additional analgesia if required and it is prescribed. You may need to flush the chest drain if the drain is not swinging and is not dislodged and you've had the appropriate training. Or you may need to talk to a senior colleague or a doctor about concerns you have and ask for assistance with pain management, flushing, or a more detailed assessment. If at any point you're worried that the patient is unwell with respect to their breathing or the chest drain, call a doctor immediately who can perform a full chest examination and is also likely to require a chest X-ray. On Cerner, you can record the observations under the OBS and Assessments tab, and then in the Lines and Devices tab, or alternatively, the HDU tab. On the left-hand side, look for the Chest Tubes tab, and then complete as best as you can by clicking on the drop-down boxes. For example, stating that you are carrying out a chest tube assessment, and so on. On Cerner, you need to record in OBS and Assessments. Look for the Lines and Devices tab or the HDU tab. After this, on the left-hand side, look for the Chest Tubes tab and complete your observations as best as you can by clicking on the drop-down boxes. For example, stating initially that you are carrying out a chest tube assessment, and so on. To record the volume of chest drain fluid output, you need to look on the Intake Output tab instead and record under Surgical Chest Drain, Tube Output. Please note that on Cerner, chest drains are often referred to as surgical chest drains. In terms of flush prescriptions, this is also true, as well as in terms of recording observations. But please use these tabs for all chest drains, including Seldinger chest drains. Here we're recording the chest drain observations for a chest drain inserted for a pneumothorax demonstrating moderate bubbling. That means bubbling when the patient is talking or breathing out.